Hello, and welcome to One-on-One with Robert Doar. I'm your host, Robert Doar, and thanks for tuning in today. As president of the American Enterprise Institute, I have the unique privilege of working with America's greatest policy experts. These scholars focus on policy issues in the fields of education, economics, energy, foreign and defense, and so much more. Subscribe to this podcast for exclusive access to in-depth discussions on the most pressing policy issues. Together, with my guests, we'll challenge political preconceptions, explore innovative ideas, and create, I hope, a freer and safer world. So this week we have the great James Capretta. Jim has been with AEI for 8.5 years as a senior fellow in fiscal policy studies or economic policy studies or deficit reduction ideas or healthcare policy studies. All those things are your world. He's one of the nicest, sweetest, kindest, best people in Washington who everyone cites and goes to for answers on this difficult question of what to do about our debt and deficit. So it's a real pleasure to have him at this time when it appears, at least from some of the noise coming from the new administration, that there's some interest in finally getting after this. Do you see a little different tone in the atmosphere?
I think in the big picture, there's certainly some level of concern about the deficit and budget, especially, I think even more so, frankly, amongst the Republicans in Congress. I think they realize they've gotten very off track. So I do hear more noise around it, and whether that leads to specific and clear and effective change, we'll see, but there's some more noise around it for sure.
So for this conversation, we're going to stipulate that it's bad, that we've made commitments that are way beyond what we are prepared to afford, and our revenues and our expenses are out of whack. Expenses are 23, 24% of GDP, and revenues are more like 17. We're going to stipulate that it's all in Medicare, Medicaid, and Social Security, because that's what we're going to focus on. Yeah. And let's put Social Security aside for a moment and really focus on healthcare, the healthcare programs, and let's start with Medicaid. So I've read some of your writing recently, and one of the things that you do hint at or say is that a pretty simple change would be to shift the burden of Medicaid more to the states and less to the federal government. The states are fiscally in stronger shape than the federal government, and they may, if they had more skin in the game, be more aggressive on controlling costs. So let's start there. What should we do to shift the burden of paying for Medicaid, which is shared between the federal government and the state governments, and some people pass it on to local government? What should we do to do that in a way that could benefit the fisc for the federal government?
Right. Well, let's start with the fact that, as you said, it's a shared responsibility, always has been. And the states about 30 years ago discovered ways, 40 years ago really, discovered ways where they could very invisibly shift some of the burden onto the federal government by basically creating their side of the revenue in ways that doesn't cause any real burden on any of their institutions or citizens. They basically tax the providers and then kind of pay them back through the Medicaid payment system so that the tax finances the state share, but there's no real burden, so they can kind of pump up total spending on Medicaid without anyone in the state really feeling it, okay? So if one were to do one thing that could save some federal money and also clean up this aspect of Medicaid that's been a persistent problem, I would move first on that, which is to disallow the worst cases of that, of which there are many examples.
Are you listening, Elon Musk? This is an easy one. And what he's talking about, I was a state official. I was a city official. I know exactly what he's talking about. It's a shell game, and it's a way that the states finance their costs by taxing the providers who benefit from more spending. And right?
That's correct, yes. And they get paid back for the tax through the payment mechanism, sometimes very explicitly, even though that's supposed to be a no-no.
Okay, so let's just say, who has the power to do that quickly?
Well, you'd have to change to really make it effective. I think a congressional change really is going to be needed because there's political turbulence around this. Every state will lose some degree of funding if you do this. And so the pushback will be pretty intense, and even on Republican states, frankly.
Yeah, but who can handle the pushback right now in Washington? The federal government can. I mean, the executive branch can. I mean, they have all the power. Trump's in charge. He's the one who's committed to this big savings. I would do it through CMS. Why defer to Congress? Won't do it. You know right now Congress won't do it.
That's actually not true.
Okay.
I think there's some possibility they might try to clean up some aspects of this in the coming year. We'll see. But having said that, I think there is some authority within CMS to go further than they've already gone. But there are already laws governing how this is done, and they might have to amend those laws to take it to the real level of big savings.
But just for our listeners to be clear, we're talking about the center. What is the M? Center on
Centers on Medicare and Medicaid Services.
So Centers on Medicare and Medicaid Services. It should be CMMS, not CMS. It's the huge federal bureaucracy. That's housed in HHS.
Yes.
The head of CMS is often more powerful than the secretary of HHS and more influential in solving the debt and deficit problem than the secretary of HHS.
Yeah.
And it's a reformer, a Trump person, a former candidate for Senate in Pennsylvania, Dr. Oz, high profile. I mean, I'm telling you, I know, and I want you to back me up on this. The person who's in charge of CMS can do some things that can make the states pay a bigger share.
Yeah.
And they should do them.
They should do them. California, I wrote about this 6 months ago. California just came forward with an additional way to essentially move money they were going to spend, another $15 or so billion onto the federal budget off of their budget, and CMS approved it. So things like that should not be allowed.
Yes,
okay.
It's just unbelievable to me. And when you talk about political pressure, that political pressure on the appointee of President Trump at this point, he's all alone. He can stand for the right thing and weather it. Where if you have to depend on getting the politics in Congress to make this happen, I feel it's a real lost
I think it's
cause.
good. Some clarity around what's allowed and not allowed legally is going to be necessary, Robert. So
okay.
I don't mean to be
so you're
difficult
saying
about
that if a strong CMS administrator tried to do some things, they'd get sued by the state.
Of course they would.
And they'd run away. Fine.
Of course they would.
Sue me. So sue me.
Of course.
Don't you know that song? We need more of that from these guys. Okay, what else? So besides shifting the burden, and again, let's stick with executive branch actions that the Trump administration can implement in order to achieve this $1 trillion worth of savings. I'll say another thing to you, James. Sometimes people ask me out in the world when I'm out on the hustings, is this Doge thing for real? Can they really get savings? And you know what I say? I say, well, if they focus on Medicare and Medicaid, they could get some real savings. They focus on Dr. Oz. That's where all the money is. So assume I'm right about that. What else could they do besides shifting the burden more to the states?
Well, they could, specifically in Medicaid, if that's what you're asking about.
Yes, so sticking with Medicaid.
Well, in Medicaid, another thing that people probably don't understand very well about Medicaid is that a huge part of the expenditure is for the elderly, actually, who are on Medicare. So a big part of the spending is for dually eligible people who get both Medicare and Medicaid, and they tend to be poor. But it's very poorly coordinated. So if you really want to save big money, where it's like multiple thousands of dollars per enrollee, tens of thousands of dollars per enrollee, you got to go after and start thinking about that, which is to try to limit and improve the health status of the people on that program so they don't end up in nursing homes. So there's actually a lot of money to be saved by better coordination of Medicare and Medicaid through the dually eligible population. There's a lot of excess that goes on there. And because it's just not well integrated. And they ought to figure out a way to work the two programs together, and there's a lot of efforts underway, and make it a much more...
Just give me an example. What are you talking about in the case? I used to run home care in New York City. I know these dual eligible. I know exactly who you're talking about. But what exactly are you talking about in terms of... Start with the patient or the recipient or the beneficiary. where is there too much spending going on for these very low income elderly beneficiaries of both programs?
Well, if someone is on Medicare and they need nursing home care and they can qualify for Medicaid, the people that are running the Medicare program don't much care if they end up in a nursing home because Medicaid pays for it. And especially if you're a managed care plan where you get a fixed budget. So you want that plan to be sensitive to keeping them out of the nursing home if they can be treated better in a different setting, especially a much less costly setting at home. So a big idea is to push more of the coordination of this onto Medicare Advantage plans, some so-called D-SNPs.
Right.
So that they have some incentive to keep the people out of the nursing home if at all possible.
And on delivery of services to recipients of this kind of care, again, I ran the home care program, which is often viewed as a way to keep people out of nursing home because you put personal aides or home health aides into the home. Are you saying more of that?
I think some more of that actually is probably going to be beneficial over the long run. But you have to have the incentives lined up properly, and they're not today. So what I'm really telling you, Robert, is get the incentives right so the plan that actually is making decisions about where the patient ends up would like to keep them in a lower cost setting. That's what needs to happen.
I'll just say that, in that home care world, it's also problematic too because you can get what are called 24-hour care, which can be expensive as well.
It can be,
and
yes.
sometimes it's less expensive to put someone into nursing homes. And the incentives were driving some providers of that care to keep people out of the nursing home because they were getting 24-hour in-home care and benefiting from that. Does it not surprise you that occurs too?
It doesn't surprise me at all. Remember, again, the incentives got to be right. So you got to tell the people that are making the decision, here's how much you get per beneficiary across a large population. Try to manage it better so that only the people that really need the most expensive settings end up in them, and the people that can be addressed and treated well outside the most expensive settings can be kept out of them as long as possible.
What about, and remember, Medicaid is the program for low-income or the lowest-income Americans who can't afford any other form of health insurance. It's a huge program. It's got more recipients than really are eligible, but we won't get into that. Their income and what about eligibility standards? The way in which someone proves their eligibility. You've been a big believer in getting everybody enrolled, and so would you push back against someone like me who says we should make people prove their income status and their residency more effectively than just declaring that they're poor and therefore should be eligible?
I'm definitely not against acting against what's in law. So I think we need eligibility standards. I think they should be enforced. I think there's a big problem in our country, which is sort of a view that people don't need health insurance. They do need health insurance. And so, we're long past the point where we're going to have an alternative to Medicaid as the default option for people that can't afford anything else. So I think a lot of our country needs to just sort of accept that Medicaid is going to be a big program. It's going to be the safety net insurance program, and people that can't get coverage elsewhere are going to be on Medicaid. So instead of thinking of it as how do we get lots of people that can't get health insurance anywhere else off of Medicaid, we ought to be thinking about how do we make Medicaid work as well as possible as our safety net insurance program, of which it inevitably will remain long after we're done with this conversation.
As the manager of the Medicaid eligibility program in New York City, and I'm someone who, when I left the Bloomberg administration, achieved an uninsured rate in New York City for children of less than 4% prior to Obamacare, I don't disagree with you. But I will tell you that and I'm not sure all of this is in law, but by actions by CMS to achieve the value you say, which is we need to make sure people can get health insurance, the eligibility rules for how someone is accepted into the program have been so weakened to sort of, self-attestation.
Yeah.
There's no documentation requirement.
Right.
There's no face-to-face interview requirement. There's often at re-enrollment, it's not, are you still eligible? Prove to me that you are. but rather we assume you're still eligible, so let us know if you're not. And no one likes to do that.
Right.
So I just am telling you that the process by which someone is determined eligible for Medicaid in the United States is very easy.
Yeah. Now, look, I would say that whole system, we talk about a very good enterprise for DOJ, would be to try to figure out what is the optimal way for figuring out if someone is eligible for health insurance in what setting. Right now, under law, Medicaid can be determined on a month-by-month basis, which is completely irrational. Think of it this way.
Yeah.
If someone was, in an employment setting, you'd have to check every month if their income was allowed them to get health insurance. It would drive everybody completely crazy, right? So Medicaid, in theory, acts that way, but it doesn't act that way in practice, as you were already describing.
Yeah.
They don't actually check everybody every month. Of course
not.
It's
Sometimes
impossible.
the certification periods are 2 years.
So they really need to do is move toward a more rational eligibility period based on hard data, probably the tax data from the prior year, and say you're in or you're out for the next calendar year. Make it simple and straightforward. And don't try to check them every month because no one's ever going to be able to do that. And then once their income does go up, which we hope it does as they get into better jobs and so on, they fall off of eligibility and they can't get it anymore.
And they would move into the Obamacare programs where it's a phase. It's not like they're off of any kind of aid to help them afford health insurance. They just get shifted into the program that was intended to fill the gap between people who get entirely employer-based health insurance or privately paid health insurance and people who are at the bottom on Medicaid.
That's correct. So as soon as they get off of Medicaid, they could go probably into a premium subsidy system that was authorized by the Affordable Care Act. Yes, That's basically the idea. I think, there's lots of ways to save money in these gigantic programs. So don't get me wrong. There are ways to tighten up how it's administered. There's ways to figure out where it's being abused, of which there are many examples. But the basic fact of Medicaid being kind of the safety net insurance program that's going to be big, and it's going to probably go above the poverty line because people can't get insurance.
I completely agree.
They're going to need Medicaid, and you got to get them into it and keep them into it until their income goes up.
But before I get off this, I just have to ask one more question about this topic of eligibility for Medicaid and people's incentives. Was the incentive to stay in the workplace in order to retain health insurance dissipated by the growth of the Obamacare, Affordable Care Act programs, and Medicaid? Is job lock, which people complained about because people would stay in jobs to keep health insurance,
yes,
was that actually not a bad thing?
Well, I think there's going to be on the one hand, on the other hand, issue associated with this. On the one hand, you're right. I think there is evidence that if there was no alternative, people would tend to go into workforce more just to obtain health insurance as much as possible.
My wife would be the first to tell me, we can't take any break. What are you talking about? I need health insurance. Get back out there.
Right, exactly. So
that's why I've never not been employed for the last 35 years. I've never had a gap in employment. Did you know that, James? Never.
It's not
a
surprised
remarkable
by that,
which I'm very proud of.
I'm your employee, so I know you're a very hardworking
All right.
dedicated person. But there's another on the other hand side of this, which is if people then try to come in and say, well, people shouldn't be on Medicaid without a work requirement, that's possible. But you have to realize, first of all, it's been tried in a couple states and it's basically flopped.
Not well implemented, but that's okay.
Yeah.
It wasn't really given a fair chance.
It wasn't
as a person who's implemented work requirements in various programs, it can be done better than it was in those tests.
I think there's also a big public debate aspect to this, which is let's assume someone has an underlying health condition, right? And you say to them they can't get health insurance unless they work. There's kind of a chicken and egg aspect to this. If they have a mental health problem, maybe they need services to allow them to stabilize to go back into work.
I'm with you on that.
Yeah.
I get that. Okay, now let's talk about something else you mention often, and this is in Medicaid. Let's stick with Medicaid because sometimes people in Medicaid tell me this isn't as applicable here, but maybe it is. Prices, the providers. Is there something CMS can do in its efforts to help President Trump and DOJ and Elon Musk on prices that would help reduce our debt and deficit.
Well, you've hit on the thing I really want to talk about. So thank you for bringing up this topic, which is that I want to preface my comment here by saying that part of the complication for deficit reduction in Medicare and Medicaid is they're wrapped up into a larger health system. And so there's a big divide in our country about how to run our health system. It's made it difficult to come to an agreement on these various things. And so when you just kind of cut Medicare and Medicaid, people who want more public control are going to be resistant to that, okay? And on the other hand, people who want a private market, they don't like expanding Medicare and Medicaid. So getting to an agreement about how to do all this is very challenging. Pricing, however, is at the heart of the matter because pricing is high in both the private sector and, in many cases, the public sector. So if you can start to bring more discipline on the price per service and allow maximum savings to occur where it's irrationally high in many settings, then you're win-win. I think you can get public advocates for that and the private advocates for that. So we're hitting on, I think, the central thing CMS should be focused on, which is where are they high, why are they high, and how do you get the providers to be really willing to take a lower price? In fact, maybe where they actually specify the lower price because they want higher market share. So in both Medicare and Medicaid and in the private market, the key here is to make sure someone, you and I, will say, you know what, if I went to that lower price provider, I could save $500 myself, at which point the dynamic starts to change, okay? Now, they did a lot of price transparency efforts in the first Trump administration, which points in this direction. I give them a lot of credit for that. That was not easy to do. They did the right thing, but it didn't really get all the way there. They're like 25% of the way on this journey. They got to go a lot farther to make it easier for people to identify what's lower priced, of which there are many, many examples when they could, and then tell the beneficiary, the patient, hey, here are the 5 things, where you could get this service, 5 places. If you went to this one, you're going to save, $300 or $400 in your own pocket. Okay?
Yeah, okay, but you're I got that. This is what you always come back to is market forces in the system that allow for recipients or patients to choose a lower cost option. And the beneficiary in the scenario you just described was the patient, the recipient, the citizen who got a lower cost price out of the pocket. But we're talking about saving the federal and state and federal government money. So tell me how that works.
Well, if you set the system up right, Robert, of course, being the head of AEI, you know for sure that a market dynamic will lead all the providers to want to not lose market share, depending on how you set it up. And they all will start lowering their prices. There's lots of data showing that when these experiments have been conducted,
lowering their prices, including to Medicare and Medicaid beneficiaries, where the federal government's paying 100%.
Correct. If you do it right, you can start to bring the price pressures down across the board, okay? So it's not that easy to do. There's a lot of technical aspects to this, and I don't want to oversimplify the matter, but the whole point is for the providers themselves to say, you know what, I want to expand my market share. I'm starting to lose customers because they're gravitating to the guy who's charging less.
Yes, I got that. I'm all for that. I love that. It's taken. You've been for this for 20 years, James, and we're making some progress.
Right.
But why wouldn't you say, as the biggest payer for these services in the world? Again, we're back to the centers on Medicaid and Medicare.
Yeah.
We're not going to wait around for the market to make that happen. We're just going to tell the providers of these services, we used to pay you $1,000, now we're paying you $850.
Of course, the last 50 years have been a series of laws passed doing exactly that.
And what's that?
There are many, many examples, okay? I mean, at this point, the physicians are getting, because of those kinds of activities, the physicians are getting inflation updates that are basically like 0.25% every year, okay?
Right. So
and
the
they're
federal
complaining like crazy.
Yes, right.
Okay. Hospitals, they get an inflation update, and the measures of these things are not great, but the official measures all show them being basically paid below cost at this point. Okay. So there's still room to be had. I'm all for that. I've never really been against any savings in these areas.
Okay.
But I think you should be very cognizant of the fact that this has been a well-trod path. This is not a new.
Okay.
We've done a lot in this area. And the providers are, there's a huge pushback saying, hey, you're already gone way overboard on this. So what you need is productivity and efficiency in the system. You need the low-cost providers to get more business, okay? Not the high-cost providers, okay? So how do you make that happen is really what this is all about.
Okay, one more on my things that CMS can do. This is a prejudice, probably an ignorant prejudice, but my view of the payment system in Medicare and Medicaid, and I know Medicaid better than Medicare, is that it was set up to pay rapidly for services and for claims so that the provider who provides the care submits the claim, gets paid very rapidly. And there's millions and millions of claims involving billions of dollars. The biggest share of our government spending is in this world. And that the review of claims is pretty non-existent or weak because the principal value at CMS is to pay rapidly. But a teeny little bit of audit function or prior review before payment could just maybe get some savings of payments that really shouldn't be paid, claims that are exaggerated or fraudulently submitted. Any hope there at all, or is that just Donald Trump myth?
No, there's some hope there. You could save some money there. I think a couple things to say about this. One is that it's a huge volume. So you're talking about 1 billion claims a year run through this system. Okay.
Yes.
So it's just a gigantic system, and there's a reason why they pay quickly because a lot of these smaller operations, they don't get the Medicare revenue for 60 or 90 days. They start to fail. Okay?
Yes.
All right. So there's a lot of huge political pushback. Having said that, there's lots of studies from GAO saying, hey, there's fraud and abuse in Medicare, improper payments in Medicare and Medicaid that add up to a lot of money. They generate a lot of headlines around this, and that's all true. But when they do the follow-on look at it, it turns out that a lot of that fraud and abuse or improper payment is basically miscoded payments that once they fix the coding would get paid, okay? So there's fraud and abuse in Medicare, people who are getting money they shouldn't be. There is criminal elements in Medicare and Medicaid, always have been. There's lots of people getting paid for patients that, use no services. Okay.
Or are dead.
Or I guess that circumstance can occur.
Yes.
So, all of that, of course, is potential for billions and billions of dollars in savings. Is it hundreds of billions of dollars? I'm doubtful. Okay. But tens of billions, possibly, yes.
Well, in your career, let me ask you this: in your career of observing the intricacies of what we sometimes is referred to as the deep state, has there ever been someone at CMS who you felt was really outstanding and really made their career by being the toughest attacker of inappropriate payments or waste, fraud, and abuse in Medicare and Medicaid? Is there a hero in your? Can you think of somebody like Nick Eversack can talk about defense analysts that were geniuses, buried somewhere in the Department of Defense. I can talk about welfare reformers at the state level and people that got people off of cash assistance into work all over the country. I can talk about child support enforcement directors that collected more money from non-custodial parents that should pay. But I want to know one person in your career who was the hero of cracking down on waste, fraud, and abuse in Medicaid.
Well, that's a great question. When I was at OMB, I'll mention people at OMB.
Yeah,
How's
this is
that?
good. I like this. It's good.
We had a crack staff of Medicaid analysts led by a good longtime friend of mine, Keith Fontenot.
Okay.
Who always hired people who were, had this bone too, and they really dug into it. And there was a series of them. I don't want to name just one.
Okay.
Okay.
All right.
But they're very much top of this. So OMB's been on top of, fraudulent payments especially state games, frankly, that are pushing money onto the federal budget inappropriately. OMB has been on this for a long time, and there are many people in CMS. There's a whole unit set up around fraud and abuse.
I know that. That's what I'm wondering.
Both in the Justice Department and in CMS.
Yes.
And they're staffed by many, many people who have their whole career in the Inspector General's office.
Yes. So,
looks at all
now
these
you're making me
things.
feel better. So
There are many people worried and working on this, have been for a quarter of a century. This is not new.
Let's give them the Irving Kristol Award. Let's bring them to AI and celebrate them because it's
Yeah.
where all the spending is. It's
It's an awful lot of spending. You're right about that.
Okay. Let's clear up one thing about Medicare while we're here and just give me your version of it. And then we're going to go to revenues and the tax policy. The Biden administration, one of their number one talking points was that they did something in Medicare that reduced costs both to individuals and to the government. And we all should be proud of this thing. I think it involved prescription drugs. Where are you on that? What happened there? Was that a true net benefit to the federal government's fiscal situation?
The CBO, took a very hard look at it. It's a complicated law, the Inflation Reduction Act's drug and negotiation provisions. And they said, yeah, it'll produce some savings both for the beneficiaries and the government. So I'm not going to contradict and say that's not true. I think that's probably, over the long run, true. It's complicated by the fact that they then, because of the dynamics of it was a very complicated law, they misestimated what it might have a near-term effect. And so they rolled out a demonstration right at the end of the Biden administration that probably wiped out a good portion of the savings in the first year by spending a lot of money to cover up the unintended side effects on the beneficiaries. Basically, the way it worked was because of the way they were changing the pricing mechanism, some of the people in Medicare Part D got much higher premiums than they used to pay. And because of that, who's paying for what, a lot of the costs ended up on the plans, the private plans who were enrolling the beneficiaries, and they went up with their premiums quite a bit. So they covered those costs with new federal money, which wasn't counted when the legislation was enacted. So how that gets sorted out in this new administration will be a big factor in whether it ultimately saves a lot of money.
So in other words, the effect of it was to shift some of the costs to the plans and to the recipients.
Plans, basically.
And the Biden administration panicked and said, "Well, we can't let that happen. Somebody's hurt here. Everybody's got to be made whole."
Especially since this what became known in the last few months of the campaign season.
Okay, we're going into the last question on all of this. Last topic is revenues, and because I'm a big, we don't have a revenue problem. We have a spending problem person, as I think you are basically.
I am, yeah.
But you have written in various documents that there are areas of greater rationality in the tax code or in the revenue generation world that could lead to benefits for our fiscal situation. And why don't you just tell us your favorite two?
Well, the big one I have is that I think we ought to build into both, and I know Social Security is sort of out of our domain here, but into Medicare and Social Security both, I would build some automatic adjustment mechanisms to keep them permanently solvent in a way that both parties can live with, which by definition is going to mean a little bit on the tax side. In other words, when the trust funds get to a point where they're starting to be low on reserves, you build into how they operate so we don't get into these debates constantly, that 10 years out, there's going to be modest adjustments to try to keep them solvent. Both of those programs were always built around the premise that the working age population would pay a payroll tax rate that would be fair across generations that keep the program solvent. That's the key. So if we do some spending adjustments in both programs, which I, as you know, completely for, You're probably going to have to get a bipartisan deal. You're going to have to do a little bit on the revenue side. I'd build in some automatic adjustments to allow that to happen. So that's
and automatic adjustments are basically just automatic tax increases.
No, there's some spending side adjustments also.
They are? Okay.
Yeah, retirement age.
Oh, retirement age, yep.
Eligibility or the deductibles in Medicare.
Yeah.
Okay. How much coverage is paid for with premiums. All of that can be adjusted automatically to keep the trust funds completely solvent. And they should be. I think that's very important.
Okay. Is there a chance of that?
Yes, of course there's a chance.
Yeah.
Is it about to sail through Congress? No, it's not about to sail through Congress. But remember, both trust funds are rapidly being depleted, so something's going to give eventually.
Okay, but you didn't mention your favorite thing.
Oh, okay.
Which is the elements of the tax code that are.
Oh, I'm sorry. I should have brought that.
That are driving up healthcare costs, and I think the number one of those is the fact that employer provided health insurance is not taxed, and you've always been for that, and that seems to go nowhere. Any hope in what about that one?
Well, not only it actually went somewhere, but then got repealed.
Yes,
How's that?
That's right. Yes.
So we had a Cadillac tax that
That's
the
right.
Obama administration enacted and got repealed. So I'm sorry, I really should have put this number one.
Yeah, that is okay.
All right. So,
but
there is a big tax break for employer-based health care. It's open-ended. It does encourage too much migration toward that kind of compensation and away from salaries and wages. And, it needs to be limited in some way. And the best way to start is probably just to limit it for high-income taxpayers who are the biggest beneficiaries of the tax break, and just set an upper limit and say it only applies to people above a certain income level. So you protect low-income and, a lot of union workers. But there's no reason why you need a tax break, above $25,000 health plan for, rich executives. So you could limit that. It would have some beneficial effect. It would generate pretty good amount of revenue too.
So you also have in a paper you wrote for us, you said Medicare spending would be reduced further by raising the general premium rate from 25 to 30%.
Yes.
Does that require a congressional act?
Yes, it does.
Tightening the reimbursement rules for hospital-affiliated clinics, so-called site-neutral payments. Does that require a congressional act?
It does, yes.
And gradually raising the eligibility age for the program so that it conforms to current law under Social Security, which means it starts at 67.
Correct.
That definitely requires a congressional.
All three do, yes.
But all three of those ideas are there. They're sitting right there. They would be pretty significant revenue producers or savers, which leads me to one other thing that I want to ask you about, sort of your general mood. When I read your writing on this topic, what I conclude is we know how to solve this. There are lots of great ideas. And they're great ideas because they don't put an excessive burden on the American taxpayer or the American economy. And the American taxpayer and the American economy could absorb it, not painlessly, but could absorb it. We are that affluent. There's that much money in our economy. Do you agree with that?
Absolutely.
Yes.
Yeah,
so do I.
You nailed that one.
Yeah. And that means that. We don't have to be depressed because we got something in the bank account. We got something there that if we finally decide to do it, we can call on it, and it's not going to destroy our economy or make Americans sacrifice really anything too much more than what we've ever done in the past.
No, definitely it's doable. It's completely doable.
Yeah.
As an example of that, just to think back, we raised the retirement age in Social Security in 1983. Most Americans don't know that that's been going on for the last 20 years.
Click, click, click every
It's
year.
been going up.
Yeah, yes.
And you don't see a gigantic congressional debate about it. There's nobody marching on Washington, okay? Of course, people would like more, and they'd like it faster. But when the rules are set in a way that everybody can agree to on a bipartisan basis, or more or less not everybody, but a good consensus around it, it brings some stability to things. And that's sort of what we need. We need a compromise that just sort of settles this matter to some degree, and not even, frankly, for the next 5 years or 10 years. You need to target this 15 and 20 years out and get the thing more stable, more clear, and it's doable. It's completely doable.
Yeah. And just one more positive thing. You did a paper recently about global healthcare expenditures, and this is one that always comes up in talking points of politicians. They like to say that we spend 17% or 20% of our GDP on health care. And that's how you measured it. You measured it as percent of GDP, right?
Yes.
And what you found was that actually it's flattened. It stopped rising. It's maybe down a tick, I don't know, but at 17%, something like that, right?
Right.
And why is that? Why we're aging?
Yeah.
And I think CMS has been insufficiently aggressive in driving savings. There's all kinds of other factors about incentives that are bad. The politicians keep throwing money at this problem, and yet the percent of expenditures going to healthcare has flattened. What happened? Why is that good news going on?
Two basic things. Remember how you were talking about, why don't we just say we're going to pay less in Medicare? As I said,
use the pricing power of the federal
We've
government.
done a lot of that.
We have done a lot of that.
Yeah, and a lot of that caught up around the year 2000, and we're benefiting from that going forward. So throughout the 1990s, it was repetitive. They put huge parts of Medicare under a price-regulated system. And essentially, that's playing out now. It's much more controlled in terms of how much the pricing is.
Each passing year, it's gotten more and more controlled.
Definitely. And so that, I think, has been a big part of it, okay? The second one, so the growth that we always saw slowed down after that period, okay?
Okay.
The second big one is between Medicare Advantage and also something they didn't do in the Affordable Care Act, sort of accountable care, there has been a wringing out of unnecessary use of services. There's more monitoring by people of unnecessary service use, and that has affected the whole market. So there's been some spillover, and I think that's had some beneficial effects as well. There's a pretty good amount of evidence that that's the case. So between those two, that's sort of where we are. The big third problem is still pricing. It's too high and irrational, and it needs to be brought down. And so there's still room. We can get down to 15 easily if we got rid of the excessive pricing.
Well, that's all good news, too. I like all that. I guess you did mention the sort of the silly cause, really tragic cause celeb in our country in the last 2 months was this awful assassination of a healthcare executive. And the spilling out of this, I don't know where it comes from, this tension among people that they can't get the health care they really want because of efforts to control on excessive use or inappropriate utilization of health care. Is that a problem? Do you think that's a problem?
Well, I think part of it is who gets to decide, right? So to the extent that private insurance companies are making choices about people's health care and it's opaque and people feel like it's not supported by clinical evidence, then I think that runs into a public problem. That happened in the 1990s, and there was a big backlash. There maybe some of it's happening now. And so, healthcare is just a super sensitive topic, right? And so you have to be very careful. And these companies that are involved in this, I think more transparency and more clarity around this would be much better than, just sort of opaque processes that people find very arbitrary and unfair. So I think that's part of what's going on. And but having said that, there's possibilities for making this even less necessary through things like artificial intelligence. To the degree that insurance is run based on protocols where an intelligent system can kind of automatically determine clinical appropriateness, and you don't have so much intervention by sort of bureaucracies, that might actually improve things. And I think some of that might happen in the coming years.
If I told you that I had two experience with the healthcare industry in the last 2 years or 3 years, one involved a good friend who was a Medicaid recipient, beneficiary, not a healthy person, not someone who took very good care of themselves in their life, and partly as a result of that got very, very sick and was really in care for 5 years. An enormous amount of effort was made to keep him alive. And kept him alive, long past what he would have been able to live if he hadn't been exposed to Medicaid funding health care. And so in some respects that was a expensive, costly to the taxpayer, but successful interaction. And then conversely, I've had encounters with the healthcare system, non-Medicare, but the private sector, or through employer-provided health insurance, where the doctors were terrific. The care in the hospital or the place where I went or friends went to get the service provided was remarkable. The technology was sophisticated, and it was just amazing. So I told you two positive stories, really, about we've talked a lot about financing. Now we're talking about the quality of care. And I thought to myself, well, for all the things we say is wrong with America, but frankly, the healthcare system does provide good care when you can get it, and a lot of people can get it. Do you agree with that, or is that just I'm just being the anecdote is not evidence?
100% agree.
100% agree.
Yeah, no, I think in most cases, people in the United States, through the various complicated and messy and sometimes frustrating insurance systems we have, basically can get access to sort of the best network of community hospitals, physicians, and all the sophistication that comes with that. It's a very well-trained workforce, high-end medical training, very sophisticated research and
millions of big-hearted people working hard to care for Americans.
So I 100% agree with that. I think our problem basically is it's not well disciplined, and so there's a lot of friction that comes from irrational pricing, people trying to say you shouldn't be getting that care when maybe the patient thinks they can, and so on and so forth. So working on these things is inevitable. We're going to have to keep working at it to make it better, and I think it can be made better.
All right. With that, we will call it a day. Jim Capretta, thanks very much for being with us.
Thank you. Thanks for having me.